Good morning, good morning, good morning. My name is Jordan Dow. I'm a PGY4, giving a lecture on the EKG, Radiology, and Pharmacology lecture series. Thanks to Dr. Tang, Dr. Katawala, Dr. Pan, Saravini, Dr. Gopal, Dr. Ding, and Dr. D'Souza. So kind of to start out this lecture, we're talking about right heart strain on the EKG. I always found it helpful to think about the intimate relationship between structure and function. So the structure of the right ventricle, it's retrosternal, it's right behind the sternum. It's kidney-based shaped. If you kind of look down at it, I always like that description when you kind of look at some of the, like the cadaver images. It's anteriorly convex. It's in a normal adult person, it's 2 to 5 millimeters in thickness. And it's got this flat inferior surface that's adjoined to the diaphragm. So like I said, you know, in cross section, or if you look at the short axis or down the heart, it's this crescentic shape, maybe kidney basin. If you look at the picture on the left, you can imagine it's got that shape and it's anteriorly convex. And you can see its relationship to the left ventricle, it is smaller in size. And then kind of from the lateral view, you can see it's got this inferior surface that's flat and adjoined to the diaphragm. So if that's the anatomy of the right heart, the anatomy of the right heart, how do we evaluate that on EKG? Well, we've got 12 leads. Some of those leads are kind of taking a picture of different parts of that heart. So AVR kind of has your high right atrial point of view, and then the inferior surface of the heart, or the inferior surface of the right ventricle, is going to be 2, 3, and AVF. And then when you look at the anterior leads, you know, we kind of talk about V2 and V3 as septal, but when we're looking for right heart strain, we can look at V1 through V3, and depending on which literature you're discussing, it's plus minus V4. So V1, V2, V3, and then V4 plus minus. And then once you're V5, V6, you're talking about lateral aspect of the heart. So do we care if there's any evidence of strain on the EKG when we're looking at a right heart strain or right ventricular strain? For your chronic medical problems, things like pulmonic stenosis, mitral stenosis, chronic lung disease, pneumothorax, and congenital heart disease, maybe. You know, maybe if you have a patient who you think maybe they've got a history of mitral stenosis and they're coming in with you know, this murmur and change in their exercise tolerance, and you find signs of right heart strain, maybe that's something you discuss and you put in your chart, but it's probably not going to change your decision making. In the acute stage, we're much more interested in right heart strain and EKG to say, are we concerned about pulmonary embolism? Am I throwing this in with all my other, maybe my ultrasound and just kind of the patient's history, their well score, their D-dimer? Am I looking at their EKG saying, is there also signs of right ventricular strain to strengthen my diagnosis of PE? Or strengthen my decision to either maybe D-dimer or skip the D-dimer and just do a CT. Also for RV infarction, this is important as well. Right ventricular cardiomyopathy, and then in COVID, I think right ventricular strain is an important thing for us to just think about. You know, 2020, there was a study in the Journal of American College of Cardiology looking at right ventricular strain and its value as a prognosticator for early mortality and poor outcomes. So this is a small study, about 50 or so patients, and they were looking at the patients who had right ventricular strain on ultrasound, and they wanted to see if that's correlated with poor outcomes in those who were admitted for COVID with hypoxia. And so, you know, there were higher mortality, or there were higher incidences of acute heart injury, respiratory distress, but then when they compared the survivors to non-survivors, the non-survivors had enlarged right chambers, diminished RV function, and elevated pulmonary arterial pressure. But they were really assessing using the ultrasound. So I think in the future, it's important for us to kind of start thinking about, okay, right ventricular strain on EKG in your COVID with hypoxia patients, is this an important prognosticator? Is this something that's relevant to their care today? But just going through the literature, there's been multiple studies that have looked at right ventricular strain and its correlation with poor outcomes. So for example, in 2015, there was a study in Journal of Academic EM, basically looking at, in patients with PE, there were 3,000 patients, and they pulled about 300 or so of them, and looked at their EKG findings and compared them between the patients with PEs and those without. And those with PEs who had signs of right ventricular strain had a higher likelihood of developing hemodynamic instability, and there were higher incidences of mortality. Second study I was looking at was actually we're going to talk about later in this discussion, in which they looked at short-term adverse clinical events in patients with RV strain on their EKG, and they also had poor outcomes. And this study actually created something called the TWIST score that we'll talk about in a couple slides. But then just kind of going through the literature, there were, outside of PE, those with inferior MI had higher incidences, there was more early mortality in those with right ventricular strain on EKG, not just on ultrasound or not just evidence on a CAT scan, but on their EKG, right ventricular strain was correlated with early mortality. In patients with pulmonary hypertension, right ventricular strain on EKG was associated with patients with a worse symptom severity. And then finally, one of the studies that was most interesting to me when they were looking at patients with HFrEF or heart failure with LV systolic dysfunction, those patients, if you control for their systolic dysfunction, those with right ventricular dysfunction on top of their LV dysfunction had higher incidences of cardiovascular death, hospitalization, need for LVADs, and cardiac transplant. So isolated RV dysfunction on top of the LV dysfunction, or isolated RV strain on EKG in patients with HFrEF was associated with worse outcomes. So we know that RV strain is important. So then what is RV strain on EKG? How do we identify it? I think, probably the first time I heard this, it was presented to me as something that I need to look for S1Q3T2. It's S wave in lead 1, Q wave in lead 3, and a T wave inversion in lead 3. Going through the literature, that's not something I'm going to anchor myself to, but also I've heard, we've said sinus tach is the most common finding in PE, and a finding of right ventricular strain on the EKG in PE. But going through the literature, it depends on which study and depends on who you're asking. So this is a list of kind of all the findings of right ventricular strain that I found good literature around. And I want to use the rest of this lecture to try to kind of help us group these and maybe find which are the findings of RV strain and EKG that are most important for us. So 2010 Annals of Emergency Medicine study. This was a study where they took 6,000 patients, pulled 300 out with PE and looked at their EKG findings. And this study in 2010 did see higher likelihood ratios to find S1Q3T3 on EKG of a patient with a PE. Same with T-wave inversions in V1 through V4. Those are very common. Sinus tach and right bundle you saw in these patients as well. So these are kind of these are four very common EKG findings of RV strain that we've probably discussed in the past. In 2001, there was a CHEST article that tried to create, Daniel et al. Tried to create a Daniel score to try to go through one by one. How do you take each of these EKG findings of RV strain and try to create a score to say whether this patient has a PE or not? This study specifically was looking at risk stratified for PE. And it was kind of interesting, like what got the most points for this Daniel score for RV strain on EKG were T-wave inversions on leads V1 through V4. But then if you had just an isolated T-wave inversion in V1, you might give yourself, if it's 1 or 2 millimeters, you might give yourself 1 point. And then if it was V1 and V2, you might give yourself 2 points for each. But all four together, V1 through V4 T-wave inversions, got you 4 points. Sinus tach, they gave you 2 points. And so the Daniel score greater than 10 was highly suggestive of RV strain from a PE. And a score less than 2 was 85% specific to say that there was not a PE. This study eventually was kind of validated and was shown to not be helpful, and that's why we don't use the Daniel score. In 2015, the study that I discussed earlier, where we developed a TWIST score for T-wave inversions, S-wave in lead 1, and sinus tachycardia. This was a score that was used to look for right heart strain in patients with PE as well. Because once again, we care about this not just to risk stratify for PE, but also to decide, do these patients with PE need thrombolytics? Is this a patient we can just heparinize, or do we need to add on lytics because of their right heart strain? We'll be using, the CTA will be a part of that, and the ultrasound will be a part of that, but early on, They were trying to use scores like the Daniel score and the twist score to decide whether there was right heart strain, evidence of right heart strain on EKG. Twist score also was kind of when they looked at this score, it wasn't, further studies show that it wasn't, the data was not as impressive as they initially presented. And so that's why we don't use the twist score. However, in 2017, there was a clinical cardiology study that was pretty interesting, looking at odds ratios of each of these EKG findings and kind of similar findings. Sinus tach, S1Q3T3, and any right bundle were associated with hemodynamic instability and PE. And this study also noted in the discussion that ST elevation and AVR was associated with PEs as well. I'm kind of saying all this to say these studies weren't very impressive and they weren't valid. The scores they developed weren't validated. But in 2017, Journal of Academic Emergency Medicine study that, or Journal of Emergency study that I did find interesting, specifically looked at the difference between EKG findings and EKG changes. So they took large pool of patients with PEs. It's a large systematic review and meta-analysis. And instead of looking at what were the EKG findings of RV strain, trying to correlate that with a PE, they were trying to see, how do I look at the EKG findings today, correlate them with the prior EKG from these patients, and see, okay, today when they came with their PE, what EKG changes did they have? And I think this is helpful because we don't want to just see what EKG findings do patients with PE or patients with RV strain have. We want to know what changes on the EKG do they have when they have RV strain? What changes are evident? And so in this study, some of them were the EKG findings that were correlated with RV strain were more specifically just the T waves. The T wave inversions and T wave flattening in inferior leads and leads V1 through V4. I guess T wave inversions specifically, where you saw 34% of these patients. T wave flattening, you saw in 28% of these patients. And then something I thought was interesting, but you didn't see any change in new left bundle in these patients with PE. No left axis deviation, and very seldom did you see AFib, A-flutter, or S1Q3T3. More often you saw, like I said, T wave flattening, T wave inversions, and then right axis deviation and sinus tachycardia. So I think this study kind of made me feel a little more comfortable with which findings we're seeing, which EKG changes we see in patients with PE and RV strain. This is just kind of summarizing this study. They also looked at how many patients had EKG changes at all. So 24% of patients had no change in their EKG when they presented with the PE. And I think that's just important for us to know that EKG is important in your patients who come in with PE or RV strain. There's likely going to be an EKG change. More common, it's going to be, based on this study, it's going to be an inferior T wave inversion or flattening in the inferior T waves, or sinus tach. If you see right bundle, you see right axis deviation, that can strengthen your suspicion for RV strain. But if you see S1Q3T3, if you see AFib, make sure your differential is a little bit broader. So that's summarizing that study. I wanted to go through a couple EKGs in the last 5 minutes of the lecture. Anybody in the chat or here want to go through my first example EKG with some RV strain? Or anybody, instead of, you don't have to go all the way through it. Anybody want to look at the leads that would be associated with RV strain and tell me what you see? Yeah. Okay, good. T wave inversions in V1 to V3. I do see, and included V4. You kind of have like this maybe inverted biphasic. Like I said, once you're getting to V4, you're starting to get out of the realm of the right side of the heart, but you can see these obvious T wave inversions in V1 to V3. And just of note, in addition to them being inverted, they're also deep and symmetrical, and that usually is a sign of fatness. Good. And you can also see T wave inversion in inferior leads too. Example 2. Anybody want to take a shot? What we also see here?
Yeah, same thing. T wave inversion and 3 AVF,
Mhm.
V1, V3, and then AVR. Looks like it has an elevation.
Exactly, and you see AVR too. And I think and the last thing I want to mention on here is that they mentioned a dominant R wave in V1, and I didn't measure this one, but know that it's taller than 7 millimeters is one of the less common findings of RV strain, but important to look for. This is a more interesting EKG. This is a patient who came in with foot pain and said that every time they had foot pain or every time their feet hurt, they developed palpitations and shortness of breath. What findings do we see here? Just to kind of skip you forward, I think that foot pain was more DVT. And yeah. What findings of right heart strain do we see here on this EKG? It's pretty obvious. Yeah, look at the not only you can got ST depression with the AVF, and then one other really important finding I wanted to discuss.
Some people put something in the chat.
Good, I like that. So some ST elevation in AVR, that's what we discussed in the 2017 Journal of Emergency Medicine study. They just kind of mentioned in the discussion that ST elevation in AVR may be right atrial infarction, maybe sign of PE, and so. And I think this was a relevant EKG to talk about in lieu of last week's lecture, because we were talking about ST elevation in AVR, and we discussed whether, how, I think Suvan mentioned in the group, how often do we cath patients with ST elevation in AVR, and that's not really a STEMI, and that, and they did discuss this in the study that I was looking at, and they were saying that an ST elevation in AVR should have reciprocal changes everywhere. Basically should have ST depression in every other lead, almost every other lead. So if you're worried about an MI, however, a patient with kind of like with demand ischemia or right ventricular strain, once you resolve that, or once you bring down their heart rate, if it's due to demand ischemia, that ST elevation may still be there, but the reciprocal changes you might not see them. So this patient, when their heart rate slowed down, you still saw reciprocal changes all throughout. So basically ST depression everywhere else with the persistent ST elevation in AVR. So you might be, and you still see this ST depression in the lateral leads. So even though this patient came in with foot pain, you maybe think this is DVT and PE together. If you have persistent reciprocal changes elsewhere, have a high suspicion for a STEMI with the ST elevation in AVR. This is the last example. I just put this on there because in 2-3 AVF you have ST depression, you have maybe some elevation in AVR, but you also have a delta wave here and a short PR interval. And I just want to mention that, like, although you have these findings of RV strain on the EKG, know that some of these other EKG findings or patterns can have some overlap with RV strain. So WPW often has T wave inversions and changes in those inferior leads. And they can also often have a dominant R wave, but make sure you look for that delta wave or short PR interval or something to differentiate it from RV strain. TCA overdose or sodium channel blockade can give you some of the same findings with right axis deviation and strange waveforms in AVR. Some of your chronic findings can also give you a right axis deviation in right bundle. So if you have a patient who has reason to have chronic lung disease or congenital heart disease and they have signs of right heart strain, maybe this is an acute RV strain finding. And so treat these accordingly. Don't treat everything just because you see some of the findings of RV strain. Do not treat them as PE or RV infarction, or even anchored, oh, this is COVID causing RV cardiomyopathy. So yeah, just in conclusion, how do we respond to RV strain on the EKG? Make sure if you see signs of acute RV strain and there are EKG changes from prior in those leads, have a high suspicion for PE or RV infarction, because not only can it be helpful for your differential, but it also is a good prognosticator for poor outcomes. But I think when you go through your EKG, still do your rate, rhythm, axis, interval, look at your ST changes, and then start trying to piece together whether there's RV strain on this EKG. And beware of overlaps. There are overlaps in some of these findings on EKG, and they can be for some of your RV strain mimics. So keep your differential broad. These are my references. Some really good studies, kind of some arguing with each other, and it was a good literature review.
Can you go back to the other slide?
Mm-hmm.
That S wave in V1, that's what you mean? Go back, go forward. Again.
To another EKG?
Yeah, to the conclusion part. Yeah,
Oh.
this is T wave inversion V1 to V4 and S wave in V1.
S wave in V1. So like in the twist score, S wave in lead 1, or similar to like the S1 in your S1, Q3, T3, something that this specific study thought was one of the stronger findings of RV strain. But like I said, the twist score didn't really play out. But it is, S wave in lead 1 is part of your S1, Q3, T3. Just another thing to integrate into your suspicion. Can hear my.
Any questions, comments? All right, good job. Yeah, I think keep your differential wide for right heart strain patterns and kind of in conjunction with your history and previous EKGs.
Yeah, don't anchor it at PE. Even though there's a lot of studies on RV strain and PE, and that's why in the literature they talk about it a lot, but in practice, your differential should be a lot broader than just PE.
Awesome. Thank you, man.